Well, good morning, good afternoon, and good evening. Welcome to the Global Mental Health 101 webinar. My name is Kate Darty-Schmeck, and I am the co-chair for the Non-Communicable Disease NCD Working Group for the Global Health Council. I also serve as the executive director for the Global Alliance for Rheumatic and Congenital Hearts, Global Arch. The Global Health Council is the leading member organization devoted to advancing global health priorities by uniting advocates, implementers, policymakers, and other stakeholders. As part of our advocacy efforts, GHC hosts member-only advocacy working groups that connect people and organizations who are passionate about global health with resources and opportunities to take action and to make a difference. Our NCD working group unites organizations focused on improving care for people living with NCDs, including groups that focus on community health workers, mental health, clinical support, direct care, and patient and family support. We bring together a range of NCDs, including cancer, heart disease, oral health diseases, childhood onset NCDs, and more. Our working group currently focuses on educating and building awareness around NCDs with the United States government and multilateral agencies. We work to build awareness around the investment case for NCDs among multilateral agencies, including how much money could be saved with prevention, early diagnosis, and timely treatment. We also work to align the larger NCD community around engagement with the 2025 UN high-level meeting on NCDs. One of the key areas that we focus on at GHC, Global Arch, and a number of the GHC member organizations is mental health. The purpose of today's webinar is to provide an overview of the global mental health landscape and its impact individually and globally, especially in the lead up to the high-level meeting on NCDs next fall in 2025. We'll begin with a presentation about the global mental health landscape, then move into a panel featuring mental health experts who will share their experiences and their knowledge. We welcome your questions at any time. Please add them to the question and answers function on Zoom that you'll find in the bottom toolbar. Please add your questions at any point. You don't have to wait to the end. And on that note, it's my privilege to introduce James Sale. James is the Deputy CEO of United for Global Mental Health. James, I turn it to you.
Thank you so much. And it's a pleasure to be speaking to all of you today. There's a fantastic panel following me, and I don't want to take up too much of their time because I'm sure you want to hear lots from them. But I thought that I would just set the scene and highlighting some key areas of mental health that might be of interest to you. There's lots and lots of things that we could speak about when it comes to mental health. And in fact, too often we think about mental health living just within health systems or within the health sector, but actually we know that mental health is something that's a cross-societal issue and requires cross-governmental as well as across a societal response. But for the next few minutes, I'm just going to use some of the building blocks of health systems just to illustrate some key things about mental health. Next slide, please. So mental health conditions are things that are conditions that can affect anybody at any time. They make up a huge part of global disability, the second leading contributor. And unfortunately, there's a very high number, although declining, number of people who die by suicide each year. You'll see from the graph there that mental health conditions, neurological conditions, substance use conditions are those that can impact over the life course, but have a high concentration amongst young people. In fact, half of all mental health conditions are diagnosed or present themselves by the age of 18. And it's no wonder that young people around the world are calling for more attention to be paid to their mental health. Next slide, please. So firstly, I just wanted to look at the care gap. Mental health is an area of the health sector which has been left behind. Um, and in many cases, the availability of services to those that need them is very little or non-existent. 1% of the global health workforce are mental health workers, and in many countries, there's less than one psychiatrist per 100,000 people. And in fact, when we look at when we look at sort of specialisms, such as say child psychiatrists, it can be 1 in 1 million, child psychiatrist amongst a million population. So the availability of services, the mental health workforce is very, very sparse. Last year, United for Global Mental Health, we modelled, well, what could the mental health systems look like, and what impact could that have if we increased service coverage? So we took 5 of the most common, or the 5 leading mental health conditions, so anxiety, depression, bipolar disorders, epilepsy, and psychosis. And we looked at what would be the outcomes if we increase service rates. So we looked at meeting the WHO Comprehensive Mental Health Action Plan target, which all countries have agreed to, and that is increasing service coverage by half by the year 2030. And this would have over 50 million cases averted, nearly 24 million healthy life years gained, and nearly 500,000 deaths avoided worldwide. But then we looked at what would it look like if we were more ambitious? So what if service coverage of those 5 mental health conditions was increased to 50%? And we see a real significant increase in outcomes. We looked at 80% and 90%, which, and many health economists might challenge us on. But what is universal health coverage? Well, it's everybody having access to services. So we looked at what would over 90% service coverage rate look like, and the figures are truly staggering. And then we extended that to look at what would be the impact if we increase this to 2050, sorry. And there we saw 635 million cases averted, over 230 million healthy life years would be gained, and 2.4 million deaths would be avoided. And that was just looking at increasing service coverage rate to 50%, but over a longer period, up to 2050. So we can see that if we do improve the situation and we do close the care gap, it can have a real and huge impact on people's lives all over the world. Next slide, please. And then just looking at financing. So much of the conversations we have in global health come back to financing. So firstly, looking at domestic financing. There's no agreed targets for financing of mental health around the world. However, there is guidance. In the 2018 Lancet Commission on Mental Health and Sustainable Development, targets of 5% of health budgets being allocated to mental health in low and middle income countries, and at least 10% in high income countries were suggested. So we looked at the last WHO Mental Health Atlas data to look at spending of and percentages of health budgets allocated to mental health, to see how well countries were doing with those targets. And as you can see from the graph, the vast majority of countries are well behind, and some quite significantly behind their targets. We have some that are exceeding, and a few which are just on those levels, but the vast majority are well away. If you take those guiding targets and then look at what's actually being spent, we calculate that there's around a $200 billion public mental health financing gap around the world each year. Next slide, please. So looking at development assistance, aids, external finance for mental health. Development assistance for mental health, DA, MH has always been a very small amount of money that has been spent on development assistance for health. It's never exceeded 1% of development assistance for health. And when we did these figures, which was last year, the percentage of development assistance for mental health as a part of development assistance for health was less than 0.5%. We saw a drop in financing or development assistance for mental health between in recent years, from 2021 to from 2018 into 2021. This is in part due to the pandemic, but we can see how fragile development assistance for mental health is. I should say that there's been an increase if we look at go back further in time. In 1995, there was just $18 million worldwide allocated to mental health as part of official development assistance. And it reached an all-time high, as you can see from this graph, in 2018 at $161 million, which is still a very small amount. And I should say we took these figures from OECD DAC data and MEHI data as well. One of the problems with the data here is how donors are tagging their financing for mental health. Is the coding as good as it could be? So these figures could be slightly increased, but we need donors to be properly tagging and coding their development assistance for mental health. Next slide, please. So just quickly looking at legislation and policy. So using the WHO Mental Health Atlas from 2020, 86% of governments who responded, which was about 120 governments, reported having standalone mental health legislation or policies. And whilst it's very important that mental health is integrated throughout government services, it is still important that there is a single document which is outlining what the law is when it comes to mental health, and similarly with policies as well. Even though we have quite a high percentage of standalone mental health legislation and policies around the world, there are still huge issues with human rights. Legal capacity, coercion, involuntary admissions are just some of the issues which are still being practiced a lot around the world. And in fact, some issues we have with national legislation on mental health is that it can allow or even encourage some of these practices to happen. And there's just one point there about the criminalization of suicide. There's over 20 countries around the world where suicidal behavior is outlawed. And that means people who attempt suicide can be punished rather than helped at a moment of maybe their most need. And people are processed through the police and the judiciary systems rather than through the public health system. We're working hard to try and change that in all of these countries, but it just gives you an understanding, I think, an idea about how mental health has some unique issues. And in fact, you can see this in the financing, but the majority of mental health expenditure around the world of domestic funding is prioritized and spent at tertiary facilities, so psychiatric hospitals, mental health, mental asylums, these types of facilities, where the vast majority of people with mental health conditions do not need to be treated. However, due to policies, legislation, and systems that have been established, and a lack of funding, the majority of mental health systems are concentrated around these tertiary facilities. I can't think of many other issues within the health sector where people are detained against their will, held indefinitely or for very long terms for a health condition which does not require them to be there. Next slide, please. And just lastly, I wanted to speak about research. Just wait for the slide. Oh, here we go. So just looking at mental health research, there's an excellent report produced a few years ago by the International Alliance for Mental Health Research Funders, which looked at over 7,500 or 75,000, sorry, grants for mental health research around the world. And they had some really interesting results. The main thing I took away from that paper, which I'd encourage you to go and read, is that there is a hugely disproportionate amount of mental health research conducted and paid for and conducted within high-income countries. This gets to a further point that is very prevalent within mental health, and that is the westernization of mental health services, and the lack of context or local context that is put into many mental health systems around the world. And this is something which is starting to change, but you can see from the figures here, 98.6% of funding for mental health research came from high-income countries. You can see how stark that difference is. And also how the majority of mental health research is on basic research rather than clinical or applied research. And it's really holding back the progress that mental health can have. And added to this is that the amount of money that's been spent on mental health research over time has been very low compared to physical health conditions. And so mental health has a long way to go, and there's a lot that can be discovered and explored and researched to improve how we protect people's mental health, how we prevent mental ill health, and how we look after people who have mental health conditions. Those are just some key areas that I thought I'd touch upon about mental health systems around the world. As I said, this really focused on health systems, but we really should be thinking about mental health as a cross-governmental, cross-societal issue that requires inputs from the education sector or from justice systems, as I mentioned before, or social welfare interventions. All of these should be thinking about mental health, not just a health system, but I hope that gives you just a flavour of what's happening around the world. I'm happy to take any questions, and I'll hand back to you, Kate.
Thank you, James, for that presentation. That was fantastic. I think talking about the impact of mental health overall and also the impact on those who are living with NCDs and the mental health impact that it has as well on your overall physical health. I appreciate that you highlighted not just the impact on patients and their families, but also on healthcare workers and the importance of addressing those needs, as well as looking at the systems and the financing, but also extending to the changes to legislation and policies in each country for human rights, and the importance of research. On that note, I'll address some of the questions that we have in the chat. Please, as a reminder, please add any questions in the Q&A function on Zoom, which can be found on the bottom toolbar with a little, it has a little question mark. So as a note, all of the presentation, any of the presentations today, as well as the recording from today's webinar, will be shared in follow-up to today's webinar. So, James, we have a question about, can you please comment on the role of community health workers in expanding service coverage? How could they be strengthened to play a larger role in this area?
Yeah, thank you. And community health workers play an incredibly important role. I think there's two things that come to mind here. One is that there are programs and initiatives out there, such as WHO's MHGAP program, which is about providing mental health training to the physical health workforce so they can deliver a basic level of mental health services, but then also know about referral pathways. That's been successful in a number of countries, and is one that's often coupled with financing reform. So increasing capitation payments to general practitioners, to doctors, encouraging them to then take the MHGAP training and to be able to receive more patients who require mental health services. And often when people present to, a community health worker or a community health worker engages with somebody, it might be primarily about a physical health condition, but so often mental health conditions will be wrapped up in that, or be part of that, or be having an effect in some way. And so, yes, certainly community health workers are very much the sort of front line of mental health support in many ways. However, the second point I'd say is that I do feel that in global health, there's only so many things we can ask community health workers to do. We always see this sort of task shifting and approach as a way, but I do believe, as well as asking community health workers to do more, it's about supporting them, increasing the numbers of community health workers, having regular and improved salaries, but also improving the mental health specific workforce around community health workers. So we have an integrated and comprehensive system.
Absolutely. Thank you. That's fantastic. Um, we have a new question that came in about how to overcome, and this I feel like we hear all the time too, James, I'm sure you as well, how to overcome the stigma of mental health disorders that are currently existing in Eastern countries and as well as globally. I think we find that with physical health as well as mental health. And if you could talk more about the mental health side of it.
Yeah, thank you. And I'm not going to be able to speak to specific areas of the world or countries, but what I would say is that um, there's a number of different ways to approach this. It might sound a little bit, I don't know, glib, but I personally do think that mental health starts at the kitchen table, and in that if we can reduce stigma within family units, within society, within general populations, within different group through many different methods, that we can help people understand, reach out for help and feel supported in doing that. Anecdotally, I hear of friends and other people I come into contact with struggling to reach out for help because of the perceptions of their family or close friends. And so I think it's about, creating a positive environment. But it's very difficult when often stigma and discrimination can be baked into our health systems. Many mental health laws around the world even have stigma within the title. In Sierra Leone, the mental health legislation is called the 1902 Lunacy Act. When you're using discriminatory terms within the legislation of a country, how can we expect there to be a decrease in stigma and discrimination throughout the country? We also find, unfortunately, that we find this stigma and discrimination about mental health within physical health systems. And so going back to that previous point about um, upskilling and training physical health workforces to be able to understand, deal, and work with mental health and people with mental health conditions is a vitally important part of that as well.
That's fantastic. Thanks, James. We have a lot of fantastic questions that came in. I'm going to take one. We'll have one more that we'll talk about here. And then, James, I will ask if you could respond to some of the questions in the typing the responses to them so that we can highlight the panel now too. I think one of the key questions that came in is could there be any research is there any research being done currently about the culture in relation to mental health? I think this also is heavily related to the stigma around it. And patients not receiving care around mental health or their physical health. I know that happens for congenital and rheumatic heart disease, the stigma around having these conditions and the impact on their mental health. If you could talk a little bit about the research around the culture or overall mental health too.
Yeah, absolutely. And not to pass this on, but I will hold my hand up and say I'm not an expert on what specific bits of research. However, you do have an excellent speaker coming up next, in Antonis, who might be able to give a little bit more about this. In terms of research, I mentioned that on the last slide I put up about how so much mental health research is conducted in high-income countries. Again, it's very difficult for that research to really be addressing stigma and discrimination within specific contexts and at a local level, and that really suits and works for people. There's been a huge growth in mental health apps over the last 5-7 years. I feel like there's so many out there. One of the problems that we have is that there's very little if no regulation and licensing when it comes to mental health and well-being apps. And that is a significant problem. However, there are some very good ones out there, but very few of them are available in languages other than English, French, Spanish, and mostly English, to be honest. And so that's an area that could be improved very quickly, I think, is about translating mental health interventions, which may be very good and are imported from different parts of the world into other parts of the world, but translating them into languages and not just the language, but into the local context as well, and how that can be incredibly helpful for breaking down barriers when it comes to stigma and discrimination. And I'll just leave you with this one point, and it's one of my favorite sort of facts or whatnot in global mental health, is that we don't have to do everything the same way. There are some frameworks and guidance that would help us make sure that mental health interventions are fit for purpose and are good, but they should be allowed to be developed to the local context. The adolescent mental health policy in Tonga is the only public policy I've ever come across in the world that has the word love in the first sentence, and I think that's a great thing. And I think we should having more love in our public policy worldwide, not just in mental health. So yeah, that's a not a great answer, but I hope it gives you a little flavor. And sorry to throw the ball to Antonis, but he might have some ideas he'd like to add in as well.
No, that's absolutely wonderful. Thank you. And I love that. I love the love part of it. That's absolutely wonderful. And I think really highlights the work that needs to be done overall in this area. Thank you, James, for your time. And thank you so much for sharing your expertise and your knowledge with everyone and about the current global mental health landscape and for answering all the questions. I also want to thank everyone in the audience right now who is introducing yourselves in the chat, and continue please to do so, as well as asking these fantastic questions. James and the team at United Global Mental Health Action will be responding to these questions in the Q&A function, so please continue to send them. If we cannot answer them today, we will follow up with them with the answers to those. So thank you for doing that. Another quick note is that the webinar recording and the slides will be sent to all participants today. So if you registered for today's webinar, you will receive the slides and the recording. On that note, we will now move into hearing from our panel of experts. So it's my privilege to introduce, and I know James highlighted this already, but Dr. Antonis Casalas, who is the Global Mental Health Action Network Secretariat Lead and the Director of Partnerships. So Antonis, I'll turn to you to introduce the amazing panelists today.
Thank you, Kate. And yeah, big thanks to James for setting the scene so nicely. I'll just ask Chelsea and Charity to turn their cameras on. We do have an exciting panel conversation for you. I think some of the discussion we have planned is already addressing some of the questions that I can see people are having. But at the same time, it's impossible, as Kate said, to address everything just within 30 minutes. So I won't put all the pressure on our panelists to respond to everything, but we'll definitely try and get through some of these. We can certainly, there are ways to continue the conversation. I can see some of you are responding to each other in the chat, and I think, I would encourage you to continue doing that and signposting to the work you're doing in your organizations. As the Global Mental Health Action Network, we also have a number of platforms that you can join and interact, and we have working groups on data and research, on stigma, on child and youth. So there are lots of work there that you can perhaps network and also meet people to learn from each other. But perhaps let's go straight maybe into our panel and start asking some of these questions and setting the scene a little bit more. So I'm joined by Chelsea Jordan. Chelsea is a champion, a youth mental health advocate in Barbados and the wider Caribbean region. She serves as the vice president of Let's Unpack It, which is a youth-led NGO with a mission to build hope and stigma and make mental health a lived reality for Caribbean children and youth. And Chelsea is joining us today from Barbados. Welcome, Chelsea. And we also have Charity Muturi, who is a lived experience expert in global health advocacy and policy for NCDs and mental health. Charity has served in the Global Advisory Committee of the NCD Alliance, the Kenyan National Task Force on Mental Health, and is a co-petitioner to decriminalize suicide attempts in Kenya. And Charity is joining us from Nairobi. Welcome, Charity. So I think building a little bit on the issues that have been raised already and the expertise of our panelists, maybe kind of start with you, Chelsea. One thing I've certainly been seeing over the past few years is that when you ask young people what matters to them, we see kind of mental health and well-being consistently being up there as one of the top issues. And I think we definitely have a new generation of mental health advocates amongst our youth, and no doubt your organization is playing a huge role in that. So in your experience, what are young people's advocacy priorities and agendas in global mental health? And are NCDs and mental health at all included within those priorities?
Yeah, thank you so much for that question. It's a pleasure to be here. I really love this question. I love how you started because I think young people know more than ever understanding that our wellness matters, right? Whether that's physical, whether that's mental, and that's really the core of a lot of our organizations. And what I would say in Barbados, and in my organization and one that we work very closely with, mental health and NCDs are top of the list. For sure, in my organization, Let's Unpack It, focus heavily on psychoeducation, for instance, around mental health, engaging young people at camps, engaging older people at workplace wellness and workshops, because we understand that sometimes knowledge may be there, but it's not as accessible as we think. I know sometimes when we get into our spaces and forums, we kind of forget that there are people who may not know certain terms or certain slogans, or we read a research paper, but that's not for the general public, right? So that's a very big focus for us. And then meaningfully engaging young people, right? So much like this, listening to what we actually want, and not let's say what we think they want, right? So for instance, at Let's Unpack It, we have a focal points network called the Caribbean National Mental Health Focal Points Network, from 17 Caribbean islands, right? Where we brought them on board, we listened to them, and we said, here's what we're going to do for the young people. And I'll kind of explain that a bit more. And then we have resource development, right? So in Barbados, at Let's Unpack It, we created a Barbados mental health resources, for instance. And that was our way of saying the resources are out there, but young people don't know how to access them. We're going to do something about it, right? And then we partnered with UNICEF, for instance, to create a mental wellness hub, right? The Young Caribbean Minds Hub, where it's actually being used on the ground in St. Vincent and the Grenadines and in Grenada, in the aftermath of Hurricane Beryl, because we've listened to young people, seen what they want, we've heard their cries, and we're producing this, right? And then when it comes to the NCD portion, I would say Healthy Caribbean Coalition, for instance, and Healthy Caribbean Youth, who we also closely work with, their main focus is on NCD prevention and control, right? Well, on mental health specifically. But in their work, they saw the importance of incorporating mental health into agenda, because as we know, the presence of an NCD impacts one's mental health and vice versa, right? The risk factors are similar, and then obviously dealing with one helps with the other, right? So as a result of that, Healthy Caribbean Youth, which is the youth arm of Healthy Caribbean Coalition, they decided we're going to create this mental health call to action. We're going to say there's no health without mental health, right? Kind of bring it to the fore yet again, showing people, yes, NCDs are a problem. Yes, mental health is a problem, but there's a connection, right? And that call to action was basically to try to mobilize policymakers around the Caribbean to prioritize mental well-being in young people, right? And what I would say as well in terms of the connection between NCDs and mental health, I think it's very important that really look to WHO's 5x5 framework, because that mental health is now considered an NCD, right? And I think that's very important because it brings into perspective the level of urgency, right? So I'll just stop there for now. But yes, we do really include NCDs and mental health in our advocacy. And a lot of the times, those are some of our guiding principles that we really go on, because we know that the health of young people is really their currency, right? And for progressive for countries to progress and countries to be healthy, the generation that's coming up also needs to be healthy, and that should include not only physical, but the mental as well.
Thank you, Chelsea. That's really insightful, and I think giving a lot of advice as well on how people can start maybe working in that space. I'll highlight this 5x5 framework you mentioned because I can see people in the chat and questions interested in frameworks and evidence and how to work across sectors. So that's one of the frameworks that people can have a look at and consult. Maybe if I move to charity, and I think Chelsea, you are mentioning how young people are kind of championing mental health these days. Obviously, we're hoping that with the new generation of young advocates, some of the past stigma is starting to being addressed. but obviously it's a huge issue. It's been a huge issue in mental health for centuries, and it continues to be. So, Charity, in your experience, what does stigma discrimination look like in global mental health policy and practice at this point in time?
Okay, thank you for the opportunity. I am very excited to be here. And I think I'm learning a lot, even from the other panelists for today. So what does it look like? I think we have had advances in the engagement of people with lived experience in stigma globally. I personally believe that lived experience engagement does really bring an emotional angle and a real scenario angle to stigma reduction. And so for me, I'm not able to separate the two. So what does global mental health look like in terms of stigma? I would say that stigma has become a buzzword and has almost lost its meaning for a lot of people. But I think for me, it is to see how stigma itself can evolve, or our understanding of it as well. I remember when we were serving in the task force, we came together as persons with, I brought together persons living with different kinds of conditions, and not just mental health conditions, but as our community culturally views that, because you'll find even the neurodiverse or cerebral palsy and things like, the community sees that as mental health. And so when we were engaging, we looked at, key areas, access to health, which I know has been discussed in this forum a lot, access to education and employment, the issues of reasonable accommodations, and the availability of that. And I think we hear a lot about it and feel like it is being discussed, but I think we discuss mostly policies that are unideal, but on the ground, we still have a lot of stigma in terms of being able to access education opportunities or to finish. I mean, we have support groups where we have so many persons with lived experience who are remaining with 3 units, 4 units, and they are disqualified from their degrees, for example. And that is for those who've managed to go that far. Workplace as well, opportunities to employment. I think I'm very passionate about the criminal justice system, so I also see the challenges in access to justice. And we have actually been doing mental health sensitizations across 50 plus prisons in Kenya to just help even just remove people with mental illness from a special block that they have to stay in, which then is stigma in the sense that they're not able to participate socially within the prison community and so on. But apart from that, I know, I think it's James who had asked in a previous conversation, like what advances have been made. And I would say awareness has grown, not just in mental health, but across health. And in this, I'm saying specifically on lived experience and engagement. There's broadening from advocacy to policy research and system strengthening, as he has mentioned. But I think also we've had so many varied terms, as persons with lived experience. Like myself with a mental health condition, and even as I do advocacy for NCDs, I find there are so many terms. There's this group of people or alliance or organization that will talk about meaningful engagement. Some will be mental health champions, others advocates. But I think that's slowly merging together, because then you sort of only get opportunities in the line that you have joined. If you came through an organization that was talking about psychosocial disabilities, that sort of becomes your line. So I think those are my comments at the moment. I was trying to just bridge the issue of stigma and lived experience engagement. But probably one more thing I would say that has interested me as James was speaking is the issue of systemic stigmatization. Honestly, this is a new word for me. Sometimes we engage in a lot of conversations until we hear the formal name for it. And I think that we have had a lot of conversations about westernization, and I'm glad our panelists have alluded to that, because a lot of stigmatization, we think about the individual, within the family, which is, the primary environment, and then the secondary environment in the community, and then now institutions and so on. But it's just in a recent conversation that I realized, not being able to access healthcare is part of systemic stigmatization. But as someone who's been in this space for a while, I think beyond that, I think it's a systemic issue that we have in the whole sector, and we don't always quite realize it. And there's a lot of talk of contextualization of programs, say from the Western world or first world countries to low and middle income countries. But I think I'm at the point where I feel like we do need to have more genuinely African-led programs versus contextualized programs. So, for example, I was, I supported the Ministry of Health and WHO in a quality rights program to engage professionals, mental health professionals, in learning quality rights. And this is after I had gone and said, we have patients who understand quality rights, but they're asking these things from professionals who don't seem to know. And issues of contextualization really came up. As someone has mentioned, violence, coercion, abuse, from me, I see it as a person in a public service setting where most of the people coming in are severe due to being 10 to 30 years within religious circles, within traditional circles, looking for solutions. But the systemic stigmatization is that the funding will not be provided for programs that are religious, for example, and so we are not able to address that factor. Or even as a task force, we did say that every 5 years we have an increase in mental illness due to our toxic political environment, and even cases of election violence in the past. But again, funding does not touch issues of politics. And my question is, how can we reduce this systemic stigmatization in issues that are important in some continents like Africa and be able to engage it? As you said, I'm a court petitioner to decriminalize suicide attempt. And my co-petitioners are the Kenya National Commission on Human Rights and the Kenya Psychiatric Association. And even if, I only learned, as we started the process, that I would be limited, in how to discuss the case while it is in court, I've still used the opportunity to speak, and especially to speak to religious leaders and our community leaders to help. Because even as a person who struggles with suicidal ideation today, and I am still in treatment, I still feel we have a much bigger cultural than legal problem. And this is because, like even when we are doing advocacy on media, people will be asked, do you think suicide should be a crime? And they say, yes, because it is a sin. That's the thinking that people have. And, I thought it's a personal opinion, but I, even talk to people in countries that have decriminalized, and they say, yes, we have decriminalized this legally, but culturally it's still a problem, and we can't get someone in our country to talk about it. Would you mind speaking, on behalf of Africa? And so I think there's more need to have genuinely Africa-led programs, because I think when we contextualize, we have already provided. Sometimes I say we already have 95% of the context, and all we can do with 5% is add a Swahili name and probably some videos of nice African dances. But I support the suggestion that was given on MHGAP. For me, I learned MHGAP as I was starting out in advocacy, and that has been the tool that I have used, because I, speak to, whether it is in religious settings or in prisons or in schools, I speak to people with lower literacy, and the look, listen, link model has come in very easy. So let me say that one has, the MHGAP program has guided my advocacy since when I began to now, and I feel it is a very, very good tool that we can use. Thank you.
Thank you, Charity, and thanks for addressing already some of the comments and questions that are coming through. And I'm already identifying those themes in kind of what you're both saying, and coupled with what James was presenting. In global mental health, we have a big issue of inequality of money, power, and resources at a global, regional, national, and local level. And part of how we kind of want to address that with advocating for better commitments, obviously this is in the context of the lead up to the United Nations high-level meeting on NCDs and mental health next year, is by kind of maybe focusing on some of those disparities. And that's across the system. So maybe I'd like to ask a question from you, Chelsea. I can see a couple of people in the Q&A are interested in digital AI, kind of the role of new technologies in mental health. What is your view on new technology and digital mental health in this space, you know, from a youth perspective, but also more broadly?
Yeah, thanks for that question. I think COVID-19 has shown us that we can do a lot online, right? I know when we had to be at home, there are lots of resources that we had to end up pulling from. I think the role of technology is not one that should be overlooked, especially a lot of the resources that we're creating now. It's either a website, it's something online. You can have therapy sessions, counseling sessions online. I know a lot of counselors and therapists in Barbados now their practice is fully online, or they have a hybrid approach. I think incorporating technology allows you to have a wider reach. And I think especially in times where transportation may be an issue to actually getting to your therapist, or you just aren't able to accommodate that, I think is very important. But there's a flip side, and in having some discussions with some of our focal points, especially from Suriname, right, and other countries that have indigenous populations that might not be fully integrated into what we consider the general society for them, technology and that sort of thing is not easily accessible. Something that we take for granted is Wi-Fi connection, for instance, right? Or if you have a tablet, if you have a phone, right? And then in those cases, then you have to actually get on the ground with the resources and go to those people. I think as well how we approach it as well. Some societies you have to, or you should train community leaders, for instance, to go and do the work. I know Little Lions in South Africa, we had a discussion with them a couple of years back, and that's what they do. Because as Charity rightfully said, sometimes it depends on the messenger, right? We may have the knowledge, but if the persons that we are saying we're going to help aren't receiving it, then there's a disconnect, there's a problem there, right? So I think it's very important to equip people with the tools to be able to go out. So if you have to have a physical book and giving them and you train them, do that. If online works, if you're in a society where everybody is connected and that's easier, I think that's how we have to really try to adapt. I think we know that one size doesn't fit all, but we still try to put everybody into the same mold. And I think understanding who you're serving is very important. A lot of the times we get into these spaces and we get to a certain point where unfortunately we forget we're serving, we forget where they're coming from. Not everyone is as privileged as us in this space. A lot of us here, Wi-Fi connection may be spotty, right? Or the camera may not be the best, but we're here. For other people, they don't have access to this, right? I think that's very important in deciding what tools and mechanisms we go out into the community. But I think technology is one that should be grasped. We shouldn't push it aside. I think we have seen the advancements in AI. Some of it is scary, some of it is very interesting. You can literally type into ChatGPT how to model a particular program for demographic, right? Before that may have taken a week, now it takes what, 5 seconds. So I think using the technology that we have for good and really seeing how we can model it to our communities is very important. And I think young people live on social media for the most part, Unfortunately, some people get a lot of their information from TikTok and other sources that might not be as trusted as others. So I think even diversifying how we present our information, I let some pocket realize, you know, people don't go on WHO or one of the credible health resources to get information. What we did, we took that information from online, created Instagram posts, right? Created bite-sized pieces, how to cope, what is stress, what is this, what is mental health, giving people that information because it's one thing to say there are resources out there. If they aren't accessible, people don't understand. If it isn't something that people can action, then what's the point of it? Right? So even something as simple as that, breaking down all these papers that we have in our offices and all these nice frameworks to see how can we encourage people. People who aren't educated and aren't knowledgeable will not grasp the information. So to us on sitting on this side, it might be simple. 5x5 framework. Okay, it makes sense. But what does that mean to the average person, right? So I think it's very important to understand our privilege and where we sit, and also understand that it doesn't hurt our advocacy to diversify and give people in the means and wants that they need. That's the only way that we're going to able to continue the work. And I think it's very important that we decide, well, yes, this is what we have to do, and then find out how best we can work in our space.
Thank you, Chelsea. That makes a lot of sense and really interesting to conceptualize kind of mental health systems in that way. You know, there's the local, there's community, there's specialists, there's also online and other spaces. And in that context, Charity, I can see a few people interested in that kind of dual burden, if you like, of mental illness and substance use, or kind of the role of the social determinants and how, you know, profoundly mental health is shaped by poverty, unemployment, you know, experiences of trauma and things like that. So if you have any thoughts before we perhaps hand back to Katie, but if you have any thoughts on you know, policies and practices that you see kind of are working to address those dual realities, you know, both either multimorbidity or kind of social determinants in mental health, yeah, etc., within multiple sectors, as James said. Oh, you're on mute, Charity.
My apologies. Yes, so I think we do have a lot of duality, as you say it, and it makes mental illness and mental health a very dynamic issue. I think for me, it is that a lot of these issues that we address, because they cannot be addressed by health alone, it means that we also need to be um, dynamic enough to include these areas. Like, for example, because I did the MH gap very early in my advocacy journey, and it was, you know, the MH gap for mental neurological substance use. For me, I've always engaged the three together. And even as we've been engaged in policy as persons with lived experience, getting to influence policy, I have invited people from substance use, from neurology, and even then I did not know that then my family would also be affected by dementia. And I think what I would say is I have done a lot of mental health advocacy within the NCD space in promoting mental health to be a top 5 NCD, which it has. And through that time, I've received a lot of criticism, you know, by people. They're like, let's push for mental health, let's push for mental health. But one is just that realization that even within my home, with parents who have 8, 9 NCDs, there is no way we can make a mental health decision on its own. You know, we have to look at the mental health of the heart patient even before my own mental health. And so I've been able to I've been able to integrate mental health as a very key agenda within NCDs, and to push for NCDs as our collective agenda. And as a result, I have been able now to, like last week, last week, Pan, we had an NCD and mental health webinar, you know, so we had from persons with sickle cell, persons with cancer, persons living with cancer, and so on. And I was able to give, you know, the mental health angle as well. And so I think that collective advocacy, for me, I feel has been able to benefit us a lot. Even we, you know, doing advocacy and policy as persons with psychosocial disability. And, you know, there are these cold wars that we have, you know, as mental health, sometimes we feel, in the mental health space, sometimes we feel, you know, HIV is here to grab our money, and cities are here to grab our money. And so these, and we don't quite talk about it, but I think it is important too, because I believe in prioritizing NCDs. I have been able to fight a lot for mental health, and even now to help guide mental health integration in cancer and so on, because now we've gotten a mixed collective agenda. And in saying that, even I mean, I've had a few not so good experiences with persons with psychosocial, with persons with physical disabilities who also feel like, as persons with psychosocial disabilities, we are encroaching their space. And I think the same, you know, collective uh, agenda of even fighting for the mental health aspect for persons with physical disabilities who are at higher risk. By fighting together, we'd be able to gain together. So I do believe in collective advocacy, collective policy, and so on. But I'd like to quickly highlight a program that is very interesting. that I am involved in, and this is the Africa Population Health Research Center, which is a leading Africa-based, Africa-led policy, policy-relevant research organization in sub-Saharan Africa, informing policy to action on health and development. And they've partnered with Wellcome Trust in the Mental Health Data Prize, which is engaging a critical mass of African participants to engage new solutions to anxiety, depression, and psychosis. And this is a lived experience process, a lived experience led process that I have an opportunity to lead, to bring Africans across the continent to look at those key issues, the issues that we probably realize after we have spent so much money, whether it is on persons with lived experience or on research, and be able to look at what can really work for us in Africa from the lens of lived experience, and to ensure that we have even institutional mentorship and learning, so that just as mental health has benefited a lot from the disability community, and NCDs have benefited from the HIV community, we're able to provide institutional mentorship for some of these things, because this time it is me and you, James, and all of us who are here. But with the moving cogs of time, in another 5 years, in another 10 years, there will be new faces, and they don't have to learn everything we've learned the hard way. So I think I just want to promote that institutional mentorship and learning, and us mentoring other people to be able to push this forward and to learn from us would be fantastic. Thank you.
That's fantastic, Charity. Thank you. And lots of inspiration from both of our panelists, lots of ideas and resources that you can go away and have a look at. Do also engage with the Global Mental Health Action Network at gmhan.org. We do routinely touch on all of these topics that we've raised today. So I think if you're not a member already, you can find a community of people keen to discuss those. But many thanks to Chelsea, many thanks to Charity. You've both been fantastic today. And I'll hand back to Kate to close the webinar.
Thank you. Thank you, Antonis. Thank you, Charity and Chelsea. That was fantastic. I'm sad that the webinar has to end. I think this really highlights the importance of talking about mental health. And thank you to all of you in the audience, as well as for being part of this discussion and how to contribute to creating change and support for those who are facing mental health challenges. Thank you so much for that. The session, I think, clearly shows the importance of having more discussions around mental health, and really the overall, we need to do more. There were a number of questions that came through in the chat and the question and answers that we did not address fully during the webinar today, and we'll follow up with that, but really want to thank all of the panelists and the speakers today. Before we conclude today's session, a very special thank you to the United for Global Mental Health team. I personally and professionally have really, truly admired your work. It's truly incredible, and it was what an honor today to be part of this presentation. Thank you. To highlight again what Antonis just said, but the Global Mental Health Action Network is free to join as an individual or an organization. The network is a global community of advocates who seek to improve care and support for mental health. We'll include the link in the email in follow-up to today to all the registrants for today's webinar with the slides and the recording of today's webinar. As we're approaching the high-level meeting on NCDs at the UN next year, we'll be launching the Global Health Council's NCDs Working Group Key Messages in the new year in the lead up for our advocacy work. So please look out for that as well. And as I conclude today's webinar, I want to say another special thank you to Charity, Chelsea, Antonis, James, for all of your work and your presentations and sharing your knowledge. Thank you to the United for Global Mental Health team, the Global Health Council, and my fellow working group co-chairs, Katie and Eliana, and to each of you for joining today and being part of this to make a difference. Together, we're stronger, and I think that clearly shows. Thank you so much to everyone, and have a fantastic day and evening, and thank you for joining today.